Okay, and so without further ado, I'll hand over to Nikki.
Thank you. Thanks, Ruth. Hello, everybody. So yeah, if anybody feels happy to leave their camera on, it is really nice to see some faces. So it's up to you, but I'm quite happy for you to do that. So I'm going to share my screen. So let me just put my presentation on. Can you see that now? You can either put your camera on and speak to me, or I'll keep the chat screen open. So if you want to speak, but you'd rather type, just type a message and I'll be able to see that. So yeah, we're going to talk about skin lesions this morning. I think everybody is a kind of nurse practitioner or experienced practice nurses. Is that right? Yeah, one nod. Yeah.
Yes, so Nikki, yeah.
Yeah. So yeah, I'm a GP and I've been a GP for 19 years now, which is a really scarily long time. And I've always been interested in dermatology, probably from being a medical student, really. So I did a diploma in dermatology in Cardiff. And again, that was 10 years ago. So time really flies. And I've been in Lincoln nearly 3 years. I used to work in York for a long time before that. So I'm kind of more settled in Lincoln now, but still fairly new. Oh, good. I'm glad to see in the chat that you experienced nurses and deal with a lot of skin issues. So hopefully this will be very useful. So these are the learning outcomes that I've prepared for today, sort of talking about how to assess a patient presenting with a skin lesion, describing the features that determine really whether something might be malignant or benign with pigmented skin lesion, and then hopefully you'll be able to recognise some common pigmented and non-pigmented skin lesions. So this is my plan for the morning. We'll have 2 sessions. First one, they'll both be around an hour-ish, and we'll have a break in the middle. I've prepared handouts for both of them, so I can send those to Ruth to pass on to you at the end. So you don't need to make notes and write things down. Obviously you can if you want to, but if you don't need to, because everything I will say or the things that I forget to say and would have wished to say will all be in that handout. And ideally, it'd be nice if we could be a bit interactive today. So if you're happy to put your microphones on and speak, that would be great, or type in the chat equally is good. And then I just put relax on the bottom of this slide because when things are interactive, I know lots of people kind of think, but I don't want to, I want to just sit here quietly and listen. That's fine, I'm not going to pick on anybody, but if you would talk to me, it will hopefully make things more interesting and it will make my life easier as well. So we'll see. So let's start with how we assess someone who presents with a skin lesion. So much like anything else, we'd start with the history. So what kind of questions would you want to be asking in the history if someone came and said, I've got some spot or mole or something on my skin that I'm worried with? What kind of things would you be thinking to ask? Onset? Yep.
How long they'd had it for and what their worry was.
Yeah, how long they'd had it for and what they were worried about. What they're worried about is really important, isn't it? Because we always assume people are worried that it's cancer, but it may be something different that they're worried about. Gemma said how long they've had it for.
Family history.
Family history, and that's really important because a lot of skin cancers like melanomas do have genetics involved, so they do run in a family, in the family, so it's worth knowing what their family have had.
Previous sun exposure as well, because we have a lot of people that have lived abroad.
Yeah, so it's really important with skin lesions what sun exposure people have had, and living abroad's a really good marker. What else? How do you ask people how much sun exposure they've had? Because it's quite a difficult question to ask, isn't it?
I generally ask whether they use what sort of factor sun protection they use, and if they've lived in a warmer climate than the UK. Yeah,
those are really good examples, because I used to ask people sort of, have you had a lot of sun in your life? And a lot of people's thoughts when you say things like that are, well, I don't ever lie in the sun, I don't sunbathe, and their answer will be no. But you're absolutely right. If you've lived abroad or if you've worked outdoors is another good question. Those people are likely to have had a lot of sun exposure just from day-to-day living. And people don't realise that you don't have to kind of put your sun cream on and lie in the sun to get sun exposure. The sun's there all the time in the summer, and certainly in hotter climates it's more so than here. Yeah, what else would we ask about?
What about if there's been any rapid changes or growth to a lesion?
Yeah, that's really important, isn't it? So growth, what other kind of changes would you think about?
Colour changes?
Colour changes, absolutely. So growing or changing colour.
Changes to sensation.
Yeah, thinking about what kind of things.
Numbness, itching.
Yeah, or pain.
Mm-hmm.
And then I suppose linked in with that if they've been bleeding. So kind of what symptoms that skin lesion's giving. So we've covered a lot. Any more things you can think of?
What about history of immune suppression? Is that important?
Yeah, it is. So history of immune suppression, and most commonly that would be kind of medications that they're on. So lots of people are on immunosuppressants now. And if you've had immune suppression, or if you've got immune suppression at the time, you're more likely to develop skin cancers. So a drug history and a past medical history are really important from that point of view. Anything else? Oh, sorry, Christopher's put in here occupation. Yeah, occupation's important, isn't it? And that comes in with working outdoors. Is that the sort of thing that you were thinking of?
Yeah, and anything like that, or maybe hobbies or something, if they're working with chemicals or they're working with anything like that in occupation.
Yeah.
Could irritate the skin, you know, just to see what they do, basically.
Yeah, occupation and hobbies, those give other exposures, don't they? So I'm just thinking, I think we've probably covered most of the things there. I suppose I don't know whether we said, I can't remember whether we said sort of past skin issues that the patients had, and you may have said that, because if you've had kind of, particularly in terms of skin lesions, if you've had a skin cancer before, then you've probably got the kind of skin and had the sort of sun exposure that predisposes you to having other ones. So a history of any kind of skin cancer yourself is really important. Okay. So what we're going to move on to now is we're going to do pigmented skin lesions, and then after the break we'll do non-pigmented. So I've just divided it up that way. I think pigmented lesion diagnosis, one of the things that people think are really difficult when somebody comes and says, I've got a mole I'd like you to look at. We tend to think, oh gosh, what are you going to show me, and is it going to be really tricky? So we'll look at some normal and abnormal things and some ways of helping to decide whether something is something to be concerned about or not. So hopefully it will feel a bit easier by the end of this session. So what do you think of this? If somebody came and said, I want you to have a look at my mole, and they showed you this, what would you be thinking?
That it's a normal mole. It's a good shape, even colour.
Yeah, absolutely. This is exactly what you say, a normal mole, and a kind of dermatology type name for that is benign melanocytic nevus. So nevus is a word that means mole, benign because it's fine, and melanocytic because it's the pigmented cells. So normal mole is absolutely perfect. And then what do we know about moles? Most people have moles. You've probably all got some moles somewhere, and we tend to develop them in childhood or early adult life. It's unusual to develop them beyond your 40s. So people who develop them later on in life, we have to be a little bit suspicious about whether that is a normal mole that they're developing. Moles can change over time. As people get older, they sometimes become raised, but they're kind of a bit soft and wobbly on the surface, but that's a normal change. And people who've got more moles are more at risk of developing melanomas. So those are the kind of people to be particularly wary about. And then what about if someone came and said, I want you to look at my mole, and this is what they showed you, what would you be thinking with this patient?
I'd be doing a 2-week wait on that one.
Yeah, it's suspicious, isn't it?
Yeah, that really doesn't look good, does it? And that is a melanoma. So you're absolutely right, thinking, I don't like the look of that one, and thinking about 2-week rule. So what do we know about melanomas? They're the skin cancer that we're worried about when people present with moles. They're becoming increasingly common as people have had more sun exposure, I guess, through their life. So we are seeing more and more of them. And they all need 2-week rule. They all need to be removed. They do metastasize. They are quite nasty conditions. And this is what we're looking for, really. So if we look at these two that we've looked at, the normal mole and the melanoma, how can we tell the difference between those? What things suggest that this is fine, this really isn't fine?
It's not smooth, it's ragged, it's discoloured.
Yeah. And what do you mean by discoloured?
It's like a two-tone colour there.
It is. You've got light brown and darker brown. Let me just find this pointer. There we go. Yeah, so we've got a lighter brown here and a darker brown there. And by ragged, do you mean the edges of this one are kind of all over the place, whereas this is a nice...
Yeah, it's not smooth, is it?
Vertical. Yeah. Anything else different? There's no measure on this one, but how big do you reckon this one is? Pretty small, probably just a few millimeters, whereas we have got a measure here and we're looking at over a centimetre, I would say, here. So yeah, what we've just talked about can all be encompassed in this ABCD rule. When I learnt about this, it was ABCDE. Doesn't seem to have an E involved anymore, but so A standing for asymmetry. And if we think back to those two pictures, the first one's nice and symmetrical. The second one really isn't. B, the border, which you talked about, the irregular border on the melanoma and nice and smooth on the normal mole. The colour, so normal moles tend to just all be the same colour, whereas melanomas usually have 2 or more colours within them. And then dimensions. So as they're getting bigger, they're more suspicious. And the cutoff now, as a sort of general rule, is around 7 millimetres. So things bigger than 7 millimetres are more suspicious. But dimensions also in terms of if it's growing in dimension, that's a concerning thing. And when we did have an E in it, it used to stand for evolution. So things that are changing, or elevation, things that are raised. So that's a really important rule to think about when you're looking at pigmented lesions. The other way of looking at it, and this is what NICE have adopted, is this 7-point weighted checklist. I personally find this harder to keep in your head, but this is what they're recommending we do, and all the 2-week rule forms have this scoring system on them. So any major features score 2 points, things like change in size, irregular border, irregular pigmentation, and then minor features score 1 point, diameter bigger than 7 millimetres, inflammation, oozing, change in sensation, which are all things that we've talked about already. So that melanoma that we just looked at would presumably has been changing, would score loads of points on that system. But if you score 3 points or more, then you should refer 2-week rule. So although I think it's harder to keep in your head, it's kind of easy to use. And I suppose the thing that concerns me about this 7-point weighted checklist is most people are coming because they've got some kind of change, so maybe change in size or the colour's changing. And it's very easy to score 3 points for lots of normal skin lesions as well. But I guess it helps us not to miss the more subtle ones. And presumably that's why NICE have adopted that. So just moving on to this mole, and I've written on here, not all moles are so easy, because it's quite easy to decide that first one was a normal mole, and it's quite easy to decide that second one was a melanoma. But the difficult bit is most of the time when people come to us, it'll be somewhere in between. Those are the ones that are more challenging, and those are the ones that we probably more commonly see. And that's what we should be seeing, because we want to pick things up before they've got as bad as that melanoma that we just looked at. So if this was the mole that the patient showed you, what would you be thinking about this one? Thinking about those rules that we just talked about.
It looks asymmetrical and it's got irregular borders and irregular pigmentation.
Yeah. So would you be thinking I should refer this one?
Yes.
Yeah, And I think you're absolutely right. And when we think about those rules, either the A, B, C, D or 7-point checklist, it has a lot of concerning things, doesn't it? It's got different colours in it. The board, it's not symmetrical. The border's quite irregular, particularly around this bit. So yeah, absolutely. I think this is one that needs referring. And I guess the options that we've got are to refer it 2-week wait, because if we're not happy with it, to say it's completely normal, like that first mole we saw, or to kind of, if we're really not sure, to think, well, should we have another look at it in a month or two's time? Because things that are melanomas will keep changing. But the ideal is to make a decision really when you see someone. And I think I would make the same decision that you've just said. And refer that to dermatology. This, in fact, is what's called a dysplastic nevus. So that means it's changed a little bit. It's not a normal mole, but it's not a melanoma, but it's something that is thought to turn into a melanoma if you don't get rid of it. So they would, obviously you only know it's a dysplastic nevus from the histology. So you would want something like this to be cut out and then not go on to become a melanoma. So you're absolutely right. Hi, Deborah, you just joined us. I just said earlier, when you probably weren't with us, I'll do a handout for all of these talks, so you don't need to make notes and things. You can just listen and join in. So then I've got a few more moles to look at. So this is someone who would come and say, I've had a mole for years. I think this is the back, but it's changed recently and I'm worried about it. What would you think if this is what they showed you? Would you be worried about a melanoma here? Or not worried? Yep, Christopher says, so yeah, do you mean yes, you'd be worried? Yeah.
Yes, I would, because the discoloration and it's not smooth, is it, at the top? You can see it's getting a little bit ragged and expanding.
So it's really quite irregular around the edges here. This bit's darker. Presumably this is the bit of mole that they've had for a long time and this is a new bit that's grown on it. So yeah, absolutely. You need to be aware of moles that have changed and have a look. And I said when we looked at the normal moles that moles can change over time, but they don't tend to be two different colours and they can become a bit raised, but they'd still have that same nice, neat border to them. So this is quite worrying and needs a 2-week rule. And then this is obviously a lady's back and we're thinking about this one here. We'll just ignore this one for now because we'll come on to that later. But if we're thinking about this mole here and a woman says, I'm really worried about this mole on my back, what do you think about that one? Worried? 2-week wait? Yeah, I agree. So this looks really abnormal, doesn't it? Again, it's irregular. It's all the same colour, but it's really, really dark, which looks a bit odd. And it just doesn't look, it's all a bit blurred, but it just doesn't look like these other things on her back. And this is what they call the ugly duckling sign. So when you look at this back, all these other sorts of moles that we can see look very similar, but that black one, that kind of stands out as being different to all the others. And so even though it's all the same colour, it has other worrying features and it's different to everything else. So something that just looks odd is worth thinking about. 2-week rule again. What about this one? Who thinks melanoma or not concerned?
Yeah, 2-week wait for that one.
I think so. Definitely. There's sort of no doubt with this one is there that there's that it's again dark. It's probably got some lighter bits to it near the edges. It's raised and very irregular and asymmetrical. And this is what you call a nodular melanoma. A lot of melanomas are flat, so they're on the surface of the skin. A nodular melanoma is when it's raised up. So the flat ones are called superficial spreading melanomas. The raised ones are called nodular melanomas. And the prognosis in a melanoma is related to the thickness of the melanoma. So obviously ones that are thicker have a worse prognosis. And if they're raised up like this, then we can tell just from looking at them that they're thicker lesions than the ones that we see that are flat. So yeah, 2-week rule. So as I said, moles can sometimes be raised. So not everything that's raised is a melanoma. This is a normal mole, but it's become raised from the surface. And we can probably all think of moles that we've seen or that we've got ourselves that are slightly raised, but they tend to be kind of soft and a bit wobbly on the surface. And I mean, this looks like slightly different colours, but I guess that's just the way the photo's been taken, because I got it off the internet from the DermNet website, and then it said normal mole, so I know that that is normal. Now, what do you think about this one? Because I suspect if it didn't say melanoma or not, and we weren't doing a talk here about pigmented lesions, you wouldn't be thinking, is that a melanoma or not? But in the context of what we're doing, what are your thoughts about this skin lesion?
It's certainly expanding, isn't it? But it looks more like something like an infection, isn't it? Than
it does. It looks a bit like an abscess, doesn't
yeah.
it, when you look at it? And I think if you know, if we just started today by putting up this slide and saying, what do you think about it? You would probably have said, it looks like an infected cyst or an abscess or something.
Depends on the history as well, I suppose, if it was something before.
Yeah. Yeah, so the history is really important, isn't it? And that's one of the artificial things about just looking at a picture on a slide. It just looks a bit odd, doesn't it?
Yeah.
And what this is, and I haven't put this in to make it scary, but this is an amelanotic nodular melanoma. So if that was black and a bit of brown, then like that picture a couple of slides ago with the nodular melanoma, I think you'd be quite happy then to say, well, this looks a bit irregular and it's black and brown, and I think that might be a melanoma. But some melanomas don't have any pigment in them or very little pigment in them, so they can be pink. And that's really unfair, isn't it? Because when we think about moles and melanomas, the first thing we think is about being brown or black. But some of them are amelanotic and don't have that brown pigment to them, but can still be a melanoma. So I've only ever seen 2 of these in the last 10 years. So they're not common, but they're worth just being aware of, that not everything that's melanoma is brown. And so again, like we did before, so that's just a picture showing that moles, normal moles, this is a normal mole, but it's not pigmented. And how can we tell a difference? What difference? I mean, this is a bit weird because it has these little yellowy bits on it, and I don't know why, but if we've got what's a normal mole that's raised, and then we've got this one that I said is a melanoma, how could we tell a difference between these two? Can you see any differences? Or Christopher, you're absolutely right, the history would probably be different. Regular border, that's right, Sally, and the mole is nice and regular around the edges. The melanoma probably extends out here a bit and is a bit irregular. And I think one of the big differences, which you can't tell from a picture, is when you feel them. And we're always encouraged when we see people with skin lesions to touch them and feel them. And there's a rule that's really useful in terms of distinguishing benign and malignant things. So EFG, so the E stands for elevation. They're obviously both elevated, but this rule is kind of applying to skin lesions that are elevated. When you feel them, the melanoma feels quite firm. And what they mean by firm is the kind of feeling like the tip of your nose. So when you touch the end of your nose, it's not soft and squishy, and it's not hard like bone. It's somewhere in between. So it feels quite firm. And then the G stands for growth. So if you'd seen that person with the amelanotic nodular melanoma and thought, this looks really odd and I don't know what it is, but it follows this rule, and they would presumably have come with a history of it having grown and changed, and you felt it and it was firm and it's elevated, then that's a really suspicious thing. So even though it looks as if it could be an infected cyst or an abscess or something like that, I think you would find when you've kind of touched it and took the history and got all the information that you would think, well, no, it isn't. This is something different. So just be aware of those, really, that if you see things that follow this rule, that's suspicious that something might be malignant, and you would refer that 2-week rule. So what do you think about this? The history here would probably be a teenager or young adult who maybe the mum said, go and see the doctor because you've got this really dark mole on your face. commonly see them on kind of foreheads and things. What would you be thinking? Would you be worried about this mole?
I don't know if I'm right or wrong, but I don't think I would be, because it's symmetrical and smooth and even pigmentation.
Yeah.
I guess you'd have to go with the history as well, though.
You would. So, I mean, if your history is kind of, you know, that they've had this for years and years, and it hasn't particularly changed, but they'd read somewhere or someone had said, oh, really dark moles you need to be worried about them, then I think, you know, absolutely you think, well, it is symmetrical. The only thing that's slightly concerning is that it's very dark. But that history is important, isn't it, whether it's changing or not. And this is actually what's called a blue nevus, although they're not particularly blue, they're kind of more black. And we commonly see these in children and young adults. You don't tend to see them over maybe the age of 20 or something developing. So if this picture was someone who was 40 or old and had come in and said, I've got this new mole, then I think that would be more like when we talked about the ugly duckling thing before, that if there's just one and it's black and they've got no other black moles, we'd be worried about that. So that comes from the history. If they've literally had this for years and years and it's not changed, then it's not going to be a melanoma, is it? So the history is really important. And I have seen a youngish woman who had one of these, and I thought it was a blue nevus, and I kind of reassured her that that was fine. But then it played on my mind later, and I rang her back and went, I just want to get a second opinion. And I referred her, and it was a blue nevus, but the dermatology, I think, did remove it as well. So we can't always get it right, can we? We've just got to go with what we feel from the history and what we see when we examine them. So I think that what you said, Rebecca, was right, absolutely, that if the history wasn't worrying, you wouldn't be concerned by it. But what would you do if you'd seen her and you'd said, well, I'm not worried because it looks okay? What would you be saying to her to think about if you did that to her?
I'd give her the skincare leaflet about things to watch for, make sure she's using good sun protection for the future and taking care of her skin, but sort of maybe asking her to keep regular photos of it to monitor for changes.
Yeah, absolutely, perfect. And I think that's what, you know, we don't only get one shot at these things, do we? If we look at it and think, I'm quite happy, this looks fine, we can give that advice, can't we, to look out for changes in colour, size, shape, anything, all of those things that we've talked about. And then the other point is really, really useful as well, that anyone who's come with something like a mole or a skin lesion, we need to talk to them about sun care advice. So keeping out of the sun in the sunniest part of the day, wearing sun protection, really wearing sun cream between April and October every day, because our faces are out in the sun whenever we go out and do anything. So that's a really important point as well. Thank you. Can you see this mole here, the one the arrow is pointing at? Have you seen or heard about those kind of moles before? Anyone know what it's called? Any ideas? No, that's fine. So this is called a halo nevus because the white ring around the mole is the halo. And you do see halo nevi, not that uncommonly really. And what's thought to happen is that the body is mounting a kind of immune response to the mole. And so it's destroying the pigment around the mole. And a lot of these, over time, the mole in the middle will disappear as well because that immune response will fight it off. So I always learned years ago that halo nevi were fine. They were just an immune response. That's what happened with moles. But then I learned more recently that the reason for triggering that immune response can be because there's a melanoma. So actually, it's really important when you see a halo nevus to not just think, well, they're fine, it's just something that happens. You have to look at the mole in the middle of it and decide whether you're happy with that mole in the same way that we've talked about with those rules. And we're advised that you should either yourself or tell the patient to look at all their skin, because this can mean that this patient has a melanoma somewhere else. And it's the melanoma somewhere else that's activated the immune system to try and fight it off. And what that's done is formed a halo around a normal mole, but elsewhere there might be an abnormal mole. So whenever you see these, they're probably fine and nothing to worry about, but you need to just check out that mole and check out the rest of the skin as well. Oh, I just answered that. This is a really common thing that we see. You probably see these every day at work. Do you have any idea what this is? No? Anybody?
Is it seborrheic keratosis?
It is, yeah. You're absolutely right. This is what we call a seborrheic keratosis, or people call them seborrheic warts. And now that I've pointed this out, you probably will start noticing them. People come sometimes because obviously this looks quite alarming, and you know, they're commonly on people's backs, and people come and say, oh, my husband's noticed this thing on my back. I think I've got a melanoma, which is very reasonable to think that when you've got something like that. They're not malignant, they're totally harmless things, seborrheic keratosis. They sometimes feel a bit waxy on the top, and they have what's described as a stuck-on appearance. So it looks like someone's just stuck it on the skin. And I always think they look like raisins that have been kind of squashed onto the skin, because they have that sort of wrinkly surface to them. They can be a bit waxy on the top, kind of like a raisin as well. And they sometimes drop off. So bits of it or the whole of it can just fall off the skin. So if that's in the history, that a bit of it fell off, that doesn't really happen with skin cancers, but it does happen with these. So next time when you're listening to people's chests and things, just have a look at their back, because lots and lots of people have little seborrheic keratoses on their back, and you probably start seeing those. And these are the sort of things that if we recognise them as being a seborrheic keratosis, we're not really then getting into, do I think this is a benign or malignant mole? We're recognising it as being something different. And most people over the age of about 40 or 50, a lot of people have them. They often come where things rub. So you see them a lot in women near the bra straps. I don't know if you remember that picture we had earlier with the really dark mole, and I said just ignore this other one that looks a bit odd. That was a seborrheic keratosis. So it looked different to the moles. You often see them around sort of bra straps, waistlines, things where clothing rubs. Nobody quite knows why you get them. They think maybe friction plays a part, and also sun seems to play a part as well in these, but nobody's quite sure. And then we'll have a look at some things on faces. So this is obviously a pigmented area on someone's forehead. We'd want the same history, and maybe they've come because they've only just noticed that they've got it, or it's got a bit bigger, or someone said, are you worried about that thing on your forehead? What do you think this is?
From the photo, I think it looks like lentigo, but it's difficult. You'd want more history and then probably a closer look at it.
Yeah. I think you're right, Rebecca. This is what we call a solar lentigo. So lentigo is a kind of dermatology term for what we call freckle. So this is a sun freckle. And if you look at people over the age of 40, lots and lots of people have these on their faces. And as you said, the history is really important. So if they've had it a little while, if it's changing, we'd be worried about it. If it's not particularly changing and it's all the same colour, they tend to have what they call a moth-eaten border. So they're not perfectly round, but they're still quite smooth. But they're not as perfectly round as normal moles are. And the history is really important. If there's any change, in the same way as we've talked about with moles, changing colour, irregular borders, growing in size, then they can be referred. But if it's very regular, not changing, then it's a sun freckle, and they're common. And then a similar thing, if a man came with this on his nose, worried about this freckle on his nose, Would you be concerned about that one, or would you think that's a sun freckle as well?
I'd be concerned about that one.
Yeah, what are the concerning things about that?
It looks very irregular, and the pigmentation's different. It's also quite big as well for that area of the body.
It is quite big, and you're absolutely right. It's got dark bits and light bits. The borders, not even quite sure where the border goes around this bit, whether this is part of it as well. But absolutely, that one's much more concerning. It doesn't look like the neat freckle on the other one. And this is what they call a lentigo maligna. So lentigo, we said, is freckle. So this sounds like a malignant freckle. This is a bit like what we had with that. Do you remember that when I said a dysplastic nevus earlier? This is sort of the equivalent on the face, where it's changed a bit. It's not normal. And the thought is that with these, if you leave them, they'll carry on changing and become what they call a lentigo maligna melanoma. So this is sort of precancerous, but will become a melanoma if we don't do anything about it. So I think you're absolutely right. You would send this 2-week rule, and I'm pretty sure the dermatologist would want to be taking this off, which is really tricky. And it's not our problem, it's the hospital's problem, but it's difficult, isn't it, to remove all this skin off somebody's nose. They're going to need skin grafts and all kinds of things. So they're quite tricky to treat, but our job is just to get them referred up on one of the cancer forms, and preferably at this stage while they're still flat and they've not developed into a melanoma. What do you think about this one? If this was a sort of elderly person who came and said, I've got this thing growing on my face near my nose, would you be worried about that, or any ideas what it is?
I don't know what the term for it is. I'd call that like a rodent ulcer almost.
Yeah, so what would you do about that one?
Is it like a basal cell carcinoma?
Yes, it is. Perfect. It's a pigmented nodule, and a nodule means it's raised, and nodules are kind of things that are raised and bigger than a centimetre diameter, so you could get hold of it between your fingers. And BCC, basal cell carcinoma. And I've just put this in here because normally BCCs or rodent ulcers aren't pigmented. We're going to talk about those in the next session, but I put it in just because sometimes they can be pigmented and they can confuse us. The thing that would be really useful here is when we talked about that EFG rule, it would follow those rules. It's elevated. If you touched it, it would feel firm. And I've said that this person's come because it's growing. So that would make you think this is something malignant. So even if you looked at it and then thought, well, it must be a melanoma because it's brown, and referred it 2-week rule, there's no harm done there, because you've still got it referred up and treated. But yeah, absolutely right. It's a BCC or rodent ulcer. Now I've just put this in because this isn't a pigmented thing. This is a vascular lesion, so a hemangioma. And they can quite often get confused with melanomas because when you look at that, it looks a bit worrying, doesn't it? And some of them can be really, this is quite purpley, but some of them can be very black. So they vary from kind of pink through to black, and they just look a bit odd. So I don't know, has anyone heard about dermatoscopes? Do you have an idea of what those are?
Yeah, we use them here.
Yeah. And dermatoscopes have a bright light on them, and they magnify and they look sort of deeper in the skin, and they're really useful with vascular things because you could, this is what it looks like through a dermatoscope, and they tend to look like raspberries or blackberries. So if you're working somewhere where they have a dermatoscope, somebody might be happy to look at that thing. If you were worried about it and thinking, I don't know what this is, if somebody that you work with has a dermatoscope, they can have a look with that, and it can be quite reassuring if you see this raspberry or blackberry appearance. If you don't have that and you're worried about something and you don't know if it's vascular or if it's a melanoma, then refer it, and someone at the hospital would have a look and be quite happy. And I've seen ones where they are hemangiomas, but the dermatologists even aren't sure, and they remove them as well. So anything that worries you, just refer. So I gave you a clue on this one that it's benign. Any idea, what would you be thinking about this? Any ideas what this is? So it looks a bit pigmented around the edges and quite pale in the middle. I'll give you some history as well. So often we see these in kind of youngish women, maybe in their 20s, 30s, and they say, I've got this thing on my skin, feels quite firm. Had it for years, hasn't really changed, but it's a little bit painful at the moment. So I thought I'd just come and get it checked. Hasn't grown, hasn't changed. Any ideas? Okay, so this is what's called, have you heard that term before, dermatofibroma? And dermatofibromas are kind of skin lesion where there's a bit of fibrosis in the dermis, so the deeper bit of the skin, not on the surface. And when you touch these, they feel a bit like somebody's got a button underneath their skin. That's what that it sort of feels like. And they're not always pigmented. Sometimes they're just skin coloured with no pigment at all. And they think they might be caused potentially by some kind of insect bite in the past. So maybe someone's had a bite and the skin's become fibrosed, and so they've got this little scarred bit under the skin, and that's what the dermatofibroma is. They don't tend to grow over time, but sometimes they can become a little bit painful, so they might come and see someone if it's changed in that way. And the way to tell if it's a dermatofibroma is what they call the dimple sign. So you can see that that person's put their finger and thumb either side of this dermatofibroma and kind of squeezed it together, and where that blue arrow is, you get a little dimple in the middle, because that's where it's attached to the surface of the skin. So as you squeeze it, the skin just dimples in at that point. So if you see something and you're thinking, oh, that looks like it could be a dermatofibroma, and as I say, it's that sort of button under the skin feeling, and you do that and it dimples, then it most likely is. So that was all my pigmented skin lesions. I've just put these two websites on here because this is where I got the pictures from. I don't know whether you're aware of either of these. The Primary Care Dermatology Society is a really good website. If you haven't looked at it at all, I would suggest just having a look. It's really well laid out for looking at things in general practice and telling you what to do with them. So it's a really useful website. You can be a member of the society, and it's only cheap. It's only about £20 a year, but you don't have to be a member to use the website. It's got really useful information on. And then DermNet is the other one that I think is really good for dermatology conditions. Loads and loads of pictures on it, but it is in New Zealand, so sometimes their management is a little bit different to what we do, but it's really useful for kind of diagnosing conditions and looking at the pictures on there. So any questions about any of the things that we've just talked about in those pigmented skin lesions? Nothing? Okay, if there's no questions, then let's have a break now. So we'll have a break for 15 minutes. We'll start again at 10:30 for the second half. So yeah, go away, stretch your legs, have a break, have a drink, and we'll start again at 10:30. Okay.
Thanks, Nikki. I'll stop recording now and I'll start recording.
Oh, okay. Yeah, lovely. Thank you.